Yes, welcome back, guys. Today we are going to continue with the topic that we started last time. Tonight will be a short uh, session today. Okay, most of the things we handled them yesterday, and it's important we go through and we do the management. Management. We didn't handle management yesterday, so that is what we are going to handle today. Management of psychosis, and we saw there are several types of psychosis. Several types of psychosis are, um, as we saw, they have different types of management, and you saw how we dealt with them. Uh, I dealt with some types of psychosis. We did schizophrenia, we did schizophreniform, we did brief psychotic disorder, we did delusional disorder, schizoaffective disorder, substance medication-induced psychosis or the psychotic disorder, psychotic disorder due to another medical condition. As you can remember well, I explained, I'm not going to explain further. I'm just going to do the management of psychosis, specific types, and we finish. Today it will be a short time. Tomorrow we'll be having some other topics that we will start from. So uh, we said about psychotic. What is psychosis? It's very important when you are dealing with a problem. You try and understand what problem you are dealing with. So generally, if someone asks you what is psychosis, say it's a mental health issue characterized by loss of contact with reality. Hmm? It's a mental health issue characterized by loss of contact with reality, where a person may have hallucinations and delusions. Hmm? Delusions are fake feelings or fake things that you think but are not real. You see, psychosis is associated with disorganized thinking and impaired insights. It's a symptom rather than a diagnosis, you see, itself, and can occur in several psychotic disorders. And we saw the core features of psychosis were delusions, hallucinations, disorganized thinking, disorganized and abnormal motor behavior, negative symptoms like blunted emotion, lack of motivation, and reduced speech. Causes of psychosis, we said psychiatric disorders like schizophrenia, schizoaffective disorders, bipolar, which is mania, major depressive disorder with psychotic features, brief psychotic disorder, brief psychotic disorder. We talked about it. We talked about brief psychotic disorder. And then we went to substance induced drug toxicity, e.g., LSD, cannabis, and amphetamine. Withdrawals from alcohol can cause psychosis. Medical conditions like having a brain tumor, and a brain tumor can change the release or reuptake of neurotransmitters. We talked about it. Sorry. Remember the neurotransmitters that we talked about now: norepinephrine, serotonin, glutamate, and dopamine. Very important. So if you are epileptic, and you have a brain tumor, and it can cause uh, these things, even dementia and infections. We talked about them, trauma and stress and sleep deprivation. You remember? Diagnosis, clinical history and mental status examination. It's very important. Rule out medical and substance related causes. Rule out substance and medical related causes. See, brain imaging is important. Antipsychotics in treatment. See, those are kind of things that will help you in managing psychosis. Yes. Now we go down to the types of psychosis that we talked about and management. I said today we are going to have a short session, and it's only management of what we did yesterday. Yes, we talked about schizophrenia. Schizophrenia, we say duration at least 6 months or equal to 6 months. At least 6 months or more than 6 months, including delusions, hallucinations, disorganized speech and behavior, and negative symptoms. Functional impairment is significant. So, how can we manage schizophrenia? We have talked about schizophrenia, and you see, schizophrenia has negative symptoms but not positive symptoms. So, how can we manage schizophrenia? First line management of schizophrenia is we talk of antipsychotic medication, and antipsychotic medication, most of them, are like risperidone, risperidone, and then we have olanzapine, aripiprazole. Those are antipsychotic. First line, risperidone, olanzapine, aripiprazole. Those are first line. And then we have psychosocial support, cognitive behavior therapy. We have always talked about cognitive behavior therapy everywhere. Psychoeducation. So if you are new here and you are listening to my discussions, it's better you at least go back and listen to other discussions so that you, as I drop a term, you are not confused. What is Doc talking about? You get. Now, we talk about psychoeducation, social skills training. Very important to keep this person busy, at least to do something. There is rehabilitation, hmm, vocational support, community programs. Very important. ECT, electroconvulsive therapy. This is for severe treatment resistant cases. You induce this so that the neurotransmitters maybe can be jacked up and be and calm. If they are low, at least they go up so that we stop hallucinating and being delusional. Schizophreniform disorder. We talked about schizophreniform disorder. Same symptoms as schizophrenia, but duration is 1 to 6 months. May progress to schizophrenia or resolve fully. A person may be having these symptoms of delusions, hallucination, disorganized speech and behavior, and negative symptoms. And then after some time, less than 6 months, it resolves fully and is okay. Hmm? Management, same as schizophrenia, antipsychotic and psychosocial therapy, just as we have talked about. You get close monitoring for progression. You get very important. You see, these are problems that are managed as the same problems as the other, because you see that one is progressive. See, schizophrenia is progressive, more than 6 months or at least 6 months. And then we have here another called schizophreniform disorder. Same symptoms as schizophrenia. Duration is at least 6 months or below. It may progress or resolve. Management the same. Close monitoring for progression, very important. Early intervention programs, very important, so that this person cannot go to the next uh, level. Brief psychotic disorder. Brief psychotic disorder. Mhm. Brief psychotic disorder. This one are sudden onset of psychosis. A person just comes out with characters of psychosis, hallucination, delusions, mm, inappropriate behavior on wearing. You get it? Mm. Often triggered by stressors. When a person is stressed, at times you see this person does not want to put on weight. This person does not want to go to take a bath. Mm. Positive symptoms comes in. Mm. And then it may full return to baseline expected. You see, after the stressor is resolved, this person may come to, to normal. Short-term antipsychotics, e.g. haloperidol and olanzapines are very important. Psychosocial support and monitoring to check if the person is okay or can go back to the problem. Hospitalization is very important because this person may do something that may harm him or her or others. So hospitalization is very important here. Delusional disorder. That is the other one. Number four, delusional disorder. Presence of more, one or more non-bizarre delusions being poisoned, followed. You see, we talked about it in a bigger way, and this duration can be more than 1 month or at least 1 month. Functioning usually preserve outside delusional beliefs. You see, you are feeling that someone can poison you or you are being followed for some one or two issues. Hmm? So management here is antipsychotics, less responsive than schizophrenia. You should use antipsychotics in delusional disorders. See, and we talked about pathophysiology of psychosis. So when you are using antipsychotics, it is helping. How does drugs of antipsychotics help you? These drugs help you by reducing the neurotransmitter if they are high. Because a neurotransmitter like dopamine, when it is excess, because we saw even the people who take dopamine with like people who have Parkinson's disease, it induces some psychotic characters because now the dopamine neurotransmitter is high because Parkinson's is low. If someone tells you that you have Parkinson's disease, what is this person telling you? You have less. Yes, Jamaican uncle, welcome to the platform. We are continuing with last time's uh, uh, topic. Today we are dealing with management only. It will be a short topic. Now, those people who take dopamine, they are replacing the neurotransmitter in the brain called dopamine. So if you are replacing the neurotransmitter in the brain called dopamine, you know what can happen? It can go high. So in your brain, when the dopamine is high, you start being psychotic. You get it? You start being psychotic. And you start having these delusions. You start hallucinating. You saw we talked about the characters. So there is a level of dopamine in your brain that should be so that you cannot be psychotic. So that is very important so that you can differentiate between psychosis and mood disorders. Mm. You see, so that you can differentiate between psychosis and mood disorders. You see, psychosis is not like mood disorder. Let's check before we continue with the management of this psychosis, because you might confuse between psychosis and mood disorder. How can we say that this is psychosis and this is mood disorder? How can you? Because now, if you give a person who has mood disorder uh, drugs for psychosis, it will be bad. This person will start having psychosis. If you give a person who has psychosis drugs for mood disorder, it will activate and this person will come to be aggressive. Hmm? So, how can we differentiate these two so that we don't give bad drugs to activate? You get it? Before we continue with the management of the others. So, in psychosis, a mental condition involving loss of contact with reality. That is psychosis. But in mood disorders, mental disorders primarily affecting your mood, depression or mania. You get it? Main symptoms of psychosis are delusions, hallucinations. We talked about delusions, believing in things that are not reality. Hallucination, there are two types of hallucination: visual hallucination, you see, and speech hallucination. So, when you are delusional, hallucinating, disorganized thinking or behavior, you are psychotic. But when you are persistently feeling sad, elations, or irritable, this is a mood disorder. It is not psychosis. You get it? You should differentiate between mood disorders and psychosis. Reality testing in psychosis is impaired. Person may believe in false ideas or see or hear things that is hallucinating when you are trying to check or ask questions to this person to check the reality. You get it? But in mood disorder, usually intact unless severe. Unless this person has psychosis or psychotic features, a person like who has bipolar disorders, you see, those are psycho mood disorders. Hmm? So you should welcome Erica. We're talking about psychosis. Now, in psychosis, the mood component is necessarily, it can be normal, elevated, or depressed. But in the other mood disorder, central feature is mood is abnormally low or high. I'm going very slow so that you know the difference between mood disorders and psychotic features. Then we go to management and finish. Insight often poor. Person may not realize their thoughts. You are talking, speaking, but you are not realizing what you are doing. This is in psychosis. But in mood disorder, often retained, may be lost in severe cases. You see, hmm? Disorders included. Which disorders are we talking about in psychosis? Because psychosis has disorders. We have talked of schizophrenia, schizophreniform. We have talked about delusion disorders, brief psychotic disorder. We have talked about them. And then we go to mood disorders. Mood disorders are characterized by major depressive disorder, bipolar disorder, dysthymia, and cyclothymia. Those ones we talked about. We have talked about of bipolar, we have talked about of dysthymia, and you see that you can have a person with bipolar but having psychosis. So don't confuse. You should treat both of them. Hmm? Onset of psychosis is usually gradual, very gradual. You will notice some things bit by bit. But in mood disorders, it varies. Depressive episode may have sudden or gradual onset. Bipolar often starts in adulthood, early adulthood. Cause it may be in psychosis, it's chronic in many cases, especially schizophrenia. It takes a course that is chronic psychosis. But mood disorder, episodic, it comes and goes, comes and goes, and goes. Normal mood may come and go. You see, because it is being uh, caused by something. Treatment for antipsychotics, you should usually use psychotic medication. Psychotherapy is very important. Mood complication disorder, antidepressants, mood stabilizers like lithium, and psychotherapy is always important. Psychotic features, primarily undefined features present in their primary undefined features that you will see in psychosis. But in mood disorder, present only in severe form like psychosis. So these are have gone so slow so that you divide this is a mood disorder and this is psychotic. You don't start treating a person who has mood disorder with antipsychotics. You get it? Now we were on delusional disorder. We go to schizoaffective disorder. We go to schizoaffective disorder. What can we say about schizoaffective disorder? Combination of schizophrenic symptom and mood disorder. Psychotic symptoms occur when mood symptoms are not present. So, management, because it is schizoaffective disorder, you use antipsychotics. Schizophrenia is a psychotic disorder. So, what do you use? You use antipsychotics like paliperidone, quetiapine. You use quetiapine. You see that? Hmm? Then you use mood stabilizer so that this person cannot be aggressive, like valproate and lithium, or antidepressants as needed. And then we have psychotherapy, which is very important. Psychotherapy in any case is very important because we are dealing with mental issues. You see, hmm? Eh, today we are only dealing with management. We are dealing with management. If you have a question, ask. Now, there is the other one we talked about, which is substance medication induced psychotic disorder. Substance medication induced psychotic disorder. Key features here we saw are psychotic symptoms directly due to substance use or withdrawal. So, what do you do? Stop the causative agent because the psychosis is being caused by something. So, you do a drug test. You draw blood, you do drug tests, you identify what is causing these psychotic features, you withdraw. Help the patient to withdraw the substance. In the case of addiction, you know what to do. Take to a specialist. Try and help this person. Hmm? Management here, mostly you use short-time use of antipsychotics or benzodiazepines because this person has used a substance that is bringing down the neurotransmitter and causing psychotic features. So when we withdraw, at least use antipsychotic for some time, like quetiapine, olanzapine, so that at least for the short period this person is suffering, she is covered up. Hmm? Put this person in substance use treatment program for those that are addicted to substance. All the substance that we've talked about. And then we go to the seventh one, which is psychotic disorder due to another medical condition. We talked about brain tumors, epilepsy, HIV, endocrine issues like diabetes, thyroid problems. They may bring psychotic issues because they may temper. They may temper with neurotransmitters in your brain, or even some electrolytes like problems with the kidney may temper with some electrolytes in your brain. So it may bring a problem. So what do we do in this case? What do we do? We make sure we treat the underlying condition, the underlying medical condition. After we treat the underlying medical condition, we put this person in a short-term antipsychotics temporarily so that this person can recuperate and come back to normal. Check the neurological function. You may send this person to a neurologist, hmm, and medical consultations regularly because this is a person that is having a problem. Hmm. Now, there is general principles of management for all psychotic disorder. Antipsychotics, very important. First line treatment for most psychotic disorders is risperidone and haloperidol. And you saw haloperidol has its adverse effects. It can bring someone may hallucinate. And then we have psychotherapy. That is the second. These are the baseline principles of treatment of psychosis. Antipsychotics, those are drugs. Psychotherapy, for psychosis, supportive therapy, family therapy, that is what we call psychotherapy. And then we have hospitalization for those that are bad, hmm, and it has gone to a level whereby it cannot be managed at home. You take as an inpatient and you manage this as an inpatient. You see, it's very important. Psychotherapy in hospital helps because in hospitals you'll find all the professionals, the doctors, the psychotherapists, counselors, all of this will get them in hospitals. This is the second one. Psychotherapy is the second principle of treatment of a person who has psychosis. Hospitalization is the third. Hmm? The patient may be suicidal. You get it? Violent or unable to care for self. And this may bring some other complications. So, what do? You admit the patient. Admit the patient so that this patient cannot bring problems to the society and other people. So, psychoeducation, educate the patient and family on the illness that this person is going. I remember yesterday I said about people think when a person has psychosis, some people have gone for juju, and I remember the word I used. I used a sangoma. It is because those Esangomas and witches, they are clever. They know when I'm using these leaves and I give this person, maybe it induces psychotic issues. And how the psychotic issues are induced, it's by neurotransmitters. So they do it by specific things that reduces it, and this person becomes psychotic, and then they tell the person that now you will do what, we will reverse this by doing this and that. Psychosis is a mental issue. It is not induced by spirits. You get? So we kind of like treat this patient as a mental issue patient that needs help in the hospital and professionals. We continue with the fourth, psychoeducation. Psychoeducation, this is between the family members and the relative and the people around this person plus the person himself or herself. Educate the patient and the family on illness, treatment adherence, and prevention. How can you prevent it when you are having a risk of getting it? How can you prevent it when you are having another problem or you are using another substance? You see, community support, that is number five. Very important. Rehabilitation, housing, giving a job support and programs that will help these people not to have depression that may lead to psychosis. You get it? Monitor side effects, extrapyramidal syndromes that are brought by the drugs that you are giving, because those drugs that you are giving can bring other symptoms. Metabolic syndromes, you get it? Hmm? Tardive, dyskinesia, very important. So the treatment for management, we call it management because now treating psychosis is complicated, but we manage it by antipsychotics, one, two, psychotherapy, three, hospitalization, four, psychoeducation, five, community support, and six, monitor side effects both of the drugs and what you are doing. You can give a comparison chart. As I said, today's topic is short, about 30 minutes. The topic, if you have a question, if you've been listening and you have a question, it is important that you raise it up before I go out. Very soon I'll be bringing some patients who have come out to speak about their problems so that you may see these problems that we speak about are real. Those that have come out and say, I want to help someone by speaking about my condition. You'll be seeing them and you'll learn more about their life journey in these problems. You get it? Now, if anyone has a question, please put it out because I'm just about to go. I'm just about to go, and I will move to next topic. There are two special topics that we are going to talk tomorrow: Alzheimer's disease and dementia. It is a topic that has uh, been of interest to many, and that is what we are going to do tomorrow. So if you have any question about Alzheimer's disease and dementia, there, there are many of these character other diseases called even Huntington disease. Huntington disease is one of them. We will talk about it tomorrow. And the so-called diseases of the brain, we will talk about diseases of all those tomorrow. So if there is no one who has no one who has no one who has raised a question, I will go log out. I will log out and have a nice day and be blessed, all of you. Thank you again.